Good afternoon, everybody, and welcome to our midweek COVID update of the 2nd of February. Apologies for the slight late start due to load shedding, unfortunately. Anyway, let's get straight on. I'm going to start immediately with an issue which is very recent, a few days ago. And has caused quite a bit of anxiety, to some extent, a bit of confusion, a bit of perplexity, and certainly not without controversy as well. So I thought I'd kind of give you the background to the changes which have occurred in the COVID-19 regulations. There are 4 changes, essentially. The first change is that individuals that are asymptomatically infected don't need isolation anymore. In other words, you're completely healthy, you go for a test for whatever reason, either for travel or for admission to hospital, whatever it is, and you turn out to be positive, but without any symptoms, you don't need any isolation after that. That's number 1. Number 2, if you do develop symptoms, then you should isolate for 7 days now. It used to be 10 days, so that's been reduced to 7 days. And then thirdly, if you come into contact with somebody that is infected, no need to quarantine anymore, unless, of course, symptoms develop. Symptoms will, of course, one should get tested. But other than that, quarantine has been removed. And the fourth one is they've now done away with the rotational school attendance in the public schools, and particularly in the more disadvantaged schools. And now there's full school attendance and that's been a major step forward, a very important step forward. So these are the 4 changes. Asymptomatically infected individuals, no need for isolation anymore. Symptomatically infected to 7 days, not 10 days. Coming into contact with somebody, unless symptoms develop, that's been removed. And now full school attendance for those schools that had rotational attendance before. There are no other changes, There's no changes to, in other words, the mask regulations. You still have to wear a mask in public spaces. You certainly need to wear a mask if you're in an indoor situation. It's actually a criminal offense. It remains a criminal offense under the Disaster Management Act not to wear a mask in a public place. You should try and avoid the social functions, getting together, and particularly in closed spaces. All those regulations still apply. So no more. So we can't start yet with our shulbrochers. We can't dispense with wearing masks in indoor environments and so on. So what is the background to it? Why have they instituted these changes to the level 1 COVID-19 regulations? The first reason is that there's a high level where we are at a particular space. Now, I must say, this could be a temporary measure. If in a couple of months' time there's an upswing again, they could reinstate the original restrictions. So what's the background to it? First of all, where we are now, there's a higher level of asymptomatically infected individuals. So in other words, you don't really know in many cases where you got the infection. In fact, this is a study published very recently from South Africa, where they looked at individuals who enrolled in a clinical trial, and they found that, in fact, 31%, and of course, these are asymptomatic individuals, healthy individuals, 230 participants, healthy participants, 31% of them turned out to be PCR positive, were asymptomatically infected. And in fact, nearly 50% of them, in fact, had high levels of antibody, of a virus in their secretions. The CT value, the lower the level of CT, that's a cycle threshold in a PCR test, the more virus there is in their secretion. So 31% as against a trial, in fact, several trials in the pre-Omicron era, where less than 1% or up to 2.4% were positive on enrollment of the trial. So you see, now we are seeing many, many more, and I think we all know this, people that just incidentally test positive. And the corollary of that is that in many cases, one doesn't know who one's contact is. And that's one of the reasons why they've abolished the quarantine for contacts. The second level and a second reason is that we've shown, I think in many previous talks, that there already is a high level of antibodies, what you call seropositivity. Now, there was a seroprevalence study. We take samples of blood from individuals, we test them for antibodies, and there's a very high prevalence of individuals have antibodies. I've shown this before. This was taken, a study done as far back as September, and there were already between 60 to 80% of individuals having antibodies. This is probably maybe even higher now, maybe an 85%, if we were to do a seroprevalence study now. So in other words, most people, the great majority, in fact, individuals who do come into contact are already at least partially, if not fully, protected. And then the third reason is that it has been apparent now, and in the early days, we kind of thought the major spread was by droplets. In other words, the heavier particles which fall down to the ground and are not projected beyond about 1.5 meters or 6 feet. We now know that, in fact, a great deal, a significant, if not the majority, but certainly a great deal of virus spread occurs by aerosols. These are finer droplets, so finer particles of fluid, and these remain suspended in the environment for a much longer period of time. So in the early days, we thought, look, we would define a contact if you come in proximity of infected individuals within, say, about 6 feet or 1.5 meters. But however, in many cases, there is transmission well beyond that. So again, the issue of quarantining from contact has now fallen away because of that. And then fourthly, we are currently, the epidemic is at a low level. And this I've shown in the last week as well. We're certainly now out of our Omicron-driven fourth wave. If we use the criteria of less than 30 cases per week, or less than 5 cases per day, or seropositivity of less than 10%, then that would indicate, and we've reached that level, so we're out of our fourth wave. So in fact, the level of transmission is low enough for the authorities to be confident that we can institute these measures. If you look at these, and I hope I'm not going to get inundated with calls, somebody who, are they asymptomatically infected? Somebody tests positive and they got an itchy throat or they've got a bit of a cough. Do they then fall into the symptomatically infected? Somebody who has a casual contact, or the other way around, somebody who's in a situation of a function, a party, a celebration, people are close together, masks are down, there are 2 or 3 people who already are infected. I think in all these cases, one just does need to make a judgment call. One needs to kind of weigh up how intense has that exposure been. Also, is one going to be in a position of passing it on to somebody who may be vulnerable? So again, if one is asymptomatically infected, but one lives in a household where there's a granny or a grandpa, then I think it's wise to kind of do wear a mask and do try and isolate, and so on and so forth. I think the watchword really is common sense. One does need to these are regulations, they're guidelines. One has to use a certain degree of common sense and make a judgment call to take the necessary precautions if you do feel that you feel outside these boundaries over here. Where we are at the moment, we are out of our fourth wave. That's absolutely true on the criteria, but there are still cases. The COVID has not disappeared. This is the dashboard from yesterday, 3,085 new cases. I mean, 23 deaths in the last 24 to 48 hours. So it's just still grumbling along at a low level, but there is still COVID around. In the community, in fact, this is last week's solo figures, that 53 new cases. The week before, in fact, they had 32. 10 currently on oxygen, 87 cases. So again, grumbling on at a low level. So people should not kind of feel, because of these relaxation of the contact, the quarantine, isolation regulations, that we're out of the pandemic. Now we can dispense with masks. Now we can have functions. All those other regulations are still in place, and we still need to support them. Just to update on the vaccine again, this is still a fairly sorry story. Only about 60,000 individuals immunized in the last 24 hours. Our fully vaccinated is not moving up very much, 42.71%. We're still below the global average of 50.1%. So really, again, this is one of the problems and one of the criticisms, in fact, of relaxating the contact and quarantine regulations, that it may give a false sense of security, a false sense that we're over the pandemic. And again, it may accelerate vaccine apathy. And this is something we really need to guard against. It is still extremely important, not only to keep those non-pharmaceutical, those infection prevention interventions, but also to try and first of all, maintain one's vaccination protocols, and also to try and encourage people that haven't been vaccinated to get vaccinated. That's extremely important. Just really want to point out an interesting observation. If you look at where the hotspots of COVID are at the moment, it's really in the developed world, industrialized countries which have high vaccine coverage. European countries, North America, Australia, to some extent, these South American countries. And taking China and Southeast Asian countries out of the equation, because they do have high vaccine coverage, but they have very, very strict control as well. Taking them out of the equation, you see that the parts of the world where there's the lowest level of virus circulation are in the developing world, where there's in fact low vaccine coverage. And you compare it to the map of the dark green is the intensity of vaccine coverage. And again, if you actually look at these side by side, the hotspots of where the virus is more or less coincide with the countries with the highest vaccine coverage. And why is this so? Why is, for example, South Africa has done pretty well compared to European countries and North American countries and Israel, for example? Well, obviously a knee-jerk answer could be it could be an artifact. It could be the fact that we just don't test enough, and other countries are testing to a much greater extent. Also, people haven't got the same access to healthcare and are not recognized. But there are, of course, viral factors, which I'll come to just now, not peculiar to South Africa, but Omicron, of course, does cause milder illness. And there are also the human factors. I've dealt extensively with population immunity. The younger age group, the younger individuals are less likely to have more severe disease. Our median age in South Africa is 27.6, compared to, for example, the United Kingdom, 40.5. That may be a factor. Climatic, we had our fourth wave in summer, where people are more outdoors, less likely somewhat to be in a situation of transmitting infection. That may be a factor. And importantly, I think adherence to the non-pharmaceutical inventions. These are still very, very important. All these infection prevention, masking, social distancing, avoiding functions, and so on. Just to give you one example, Denmark, one of the highest vaccine coverage countries in the world, approaching 90% vaccine coverage. And they then, as a result of that, decided to remove all COVID restrictions. And this is really what happened in terms of their cases. They really shot up. And this is the same story with many European countries and some parts of the United States as well, where COVID restrictions have gone out of the window. And as a result of that, the cases have climbed up quite significantly. All right, let me go on to a slightly different topic. These are the waves that we've had now. The initial wave, our first wave, due to the ancestral variant and its offshoot, the 614G. Then we had the second wave due to the beta variant, which elbowed out. This was a fitter virus, elbowed out the ancestral strain. And then the Delta, which spread globally, the first of the global variants, that elbowed out the beta variant. And now, of course, we've got the Omicron, which is elbowing out the Delta variant. And this, of course, is a much fitter virus than the Delta. It's much more contagious, and it also escapes the immunity much better. But look what's happening now. Now we're having a subvariant of Omicron. Omicron now has developed subvariants, BA1, BA1.1, BA3, BA2. BA3 is a rare one, but BA2, which is more contagious than BA1 subvariant, is now starting to elbow its way into our environment. So this is Omicron, the fifth variant of concern, completely independent of the other alpha, beta, and gamma. And now Omicron itself is evolving sub-variants, BA1, BA2. BA1 is what we had up to now. BA2 is what's developing. And now they might still develop more sub-variants. It is now evolving. In fact, BA2 subvariant has now become the dominant one in some countries, like, for example, India and Denmark. More than 50% of their Omicron is BA2, not BA1, the more contagious BA2. In South Africa, BA2 is also starting to come in and may even overtake BA1. Now, of course, we've come out of our fourth wave, and I think it's still unlikely that we're going to go into the very near future. Probably it'll take a couple of months. But BA2 may well then become the dominant subvariant of Omicron variant. Fortunately, BA2 is less, in fact, affected, is less vaccine or immune escape. Vaccines do work slightly better against BA2, 70% as against 63% to prevent symptomatic disease. This is a summation of a number of vaccines, and it's been recently published. So we don't have to worry too much about vaccine escape with BA2. But as I said before, BA2 certainly seems to be an even more contagious subvariant. Are we vulnerable to other variants? Well, of course, Omicron took us by surprise. That was a completely new variant, not related to any of the other variants. There may well be another variant. As I mentioned before, we still got 9 letters of the Greek alphabet to come. And we do have a remnant of people that are not vaccinated who can generate more variants. And then, of course, we may have a completely new SARS-CoV-3, which could arise from the animal reservoir, as did SARS-CoV-2. You remember SARS-CoV-2 came from bats. These are all animal viruses. The horseshoe bat over here is probably one of the main reservoirs, particularly in the Far East. And you see there are many, many, many of these species which can still potentially invade humans. And it's particularly in Southeast Asia, there's a lot of contact with these reservoirs. Now, this is not to kind of make people worried. It's just to kind of give a complete overview. What we really need eventually to develop into is have the next generation of vaccines, which will maybe cover all these coronaviruses and will induce mucosal immunity to stop infection and give a more durable immune response to our present vaccines. Remember, we're still in our first generation of vaccines derived from the original Wuhan ancestral strain. There's not been any advance, maybe for commercial reasons, since then. And it really is about time that we have better vaccines. So I'm going to stop there and answer some of the questions. Thanks again for some interesting questions. My opinion on mandatory vaccination, this comes from somebody with regard to University of Cape Town. Of course, many of the institutions of higher learning are now instituting a mandatory vaccination, both for the staff as well as for the students. Of course, this really has now become a legal issue, and the courts are going to decide this. And as you know, now the CCMA has ruled in favor of mandatory vaccination and allowed employers to dismiss employees who refuse vaccination. There have now been two CCMA cases. At the moment, no court cases, but it's really going to become a legal issue. From a public health point of view, from a medical point of view, it's really a no-brainer. I think people use the argument that constitutionally one has the right to one's body, one owns body, control one's own body, has the right to privacy, and so on. But you have to weigh this against the rights of a safe workplace. And it is the employer or the superintendent of an organization, or the CEO of an organization, whoever's in charge of an organization, to ensure that these workplaces are safe places for other individuals. And that, from a human rights point of view, to my mind, needs to override the individual's choice of not having vaccine, which is not based on science, which is based either on conspiracy theories, it's based on misinformation, in some cases based on genuine religious objections. So that's my opinion. You asked for my opinion. I believe that mandatory vaccination in many workplaces should be enforced. I discussed the second question about the subvariants of Omicron just now. And the third question is one I really can't answer. And that is, how long after infection with Omicron, or how long after vaccination, does immunity last? It's too early to really kind of give it a definitive answer. We do know that there is still good immunity up to about 6 months or maybe even 8 months after both infection or after vaccination. The feeling is, from what we do know of immunological studies, is that you're not going to get long-lasting. You're not going to get the kind of immunity after measles vaccination, after mumps and rubella and polio and all those. Because it is a superficial respiratory infection, the duration is going to be quite considerably less. Unless there are newer vaccinations, the new generation vaccines, as I mentioned just now, which can provide a more durable immunity. But also after infection, again, one's not likely to have long-lasting immunity. And the other factor, of course, that the virus keeps changing. And as it keeps changing, the immunity might not be effective against the new changes. So I'm going to leave it there and wish you all a great week. And please maintain the precautions, and please don't be misled by the fact that that some regulations have been relaxed, the quarantine and isolation. It does not mean that we can dispense with the other infection preventions. Thank you very much.